Good morning. Claude, thank you for the invitation. I think a lot has been said already by a previous speaker. I'll try to give a little overview from being responsible for the teaching group in EQuiP and being a privileged observer of things happening within the Ghent faculty and within other organizations. So let's start. Teaching Quality EQuiP Working Group started in 2008 in Bucharest, the moment when Tina became our president. And that's the picture is one of the evening when the presidency was handed over to Tina. So in Bucharest we set priorities for the working group, and we had 4 priorities. What is the actual situation of teaching quality in Europe? And we managed to make a paper within which has been published last year after doing a survey. I'll show you a little details of it. Then we wanted to build a consensus of what should be done. Can we organize and make a framework of what should be done on teaching quality? The idea of spreading good practice and showing good examples, which is continuous work, and organize a summer school. So I'm very pleased that we are organizing the 3rd and the 4th summer school this year already. In 2010 we made an online questionnaire, and we had 176 answers from 29 European countries about what is happening in teaching quality, and we published this in Education for Primary Care last year. But we had a topic list within the online questionnaire with 10 topics of which we thought in 2008-2010 were important in teaching quality, and there was not one about equity, social accountability or community-oriented care, not one. We moved on. In Copenhagen in 2010 we had a workshop within the Leonardo da Vinci project about developing a competency framework on quality improvement for GPs in Europe. And we had several Delphi rounds afterwards with a lot of experts. And this was published in the Journal of Continuing Education and Health Profession, also in 2012. And we managed to make this competency framework for quality improvement for GPs in Europe. It is done from the idea of looking to continuous professional development and CME, but I think it is also even the same competencies are needed for academic training and especially vocational training. So there is not a lot of difference between. And you see there we have on the top equity and ethical practice emerging as being part of the competency framework. Okay, what is in it? We have 2, 4, 6, 8 topics which are about equity and ethical practice, and some really are about equity. So we think all GPs should be able to analyze the equity of the practice performance and take actions when necessary. I thank the first speaker of today to show how important this is, and it is feasible and it's possible to do so. Another one is to understand intercultural patients' concerns. We also think this is an important and essential competency for our GPs, and understand the social context and general practice. So these are things we think are essential to put into continuous medical education programs and to screen programs if things like this are coming into it. Reflect a little bit if this happens in your country, yes or no. I am, as I told you, a privileged observer of a global movement. When we come from competencies is something already happening. And yes, something is happening. Something very interesting. We have some important publications. The first one is a Lancet report on health professionals for a new century, focusing on how we should reframe teaching to be apt for 21st century problems, and how we can help with the health professionals to tackle these problems. And then we have there is a global consensus on social accountability being one of these problems in the Lancet report. And then I will end with showing the existence of a medical school network, a global school network, which is already starting to introduce things like that within medical training. So the Lancet report, Health Professionals for a New Century, tells one of the things which is told in it is that social accountability, which is introduced by the last speaker before me, is of great importance. And one of the things the Lancet report says is that, well, we had important things done within the medical curricula, but what the medical curricula and what the medical profession hasn't been able to do is to diminish inequity in health and inequity in health care. So it was an independent commission, I think, of about 20 experts who made this report and said there are 5 essential things we have to take into account or to introduce in modern medical teaching. And this is, the curriculum should be competency-based, and we have offered competency framework for it by our EQuiP also. It will be very important to think about the creative use of information technology. What can we do with it? And I think this is really something which is not really introduced within medical curriculum. Another one is transformative learning. I think this is a very interesting topic, but I think we need an hour to tell what it is about. But I try to say it in 3 words. Informative training is the start. Informative training means you learn people, or you give people information on what they should do. So this is about knowledge. That's informative training, and handing over knowledge. And that's the first level. And that's what medical schools are very good at. Most medical schools does this very good. Then you have formative learning, which is the learning in which you teach people how to behave professionally, how to organize and things like that. But then we have the third step, and that's transformative learning. And that's learning people how to make change in practice, and how to organize and how to become leaders in changing your practice and introducing quality and taking responsibility for that. So that's about transformative learning. And I think it's important to read the Lancet report on that and to think about medical curriculum and being, if this is already introduced within the curriculum. But the last speaker is also emphasized, and I think this is also a very important aspect, that we should change from medical training into professional teamwork. And if I look into my country, this is a major problem. We have very good doctors, but very bad team players. And I think that's not only a problem in Belgium. And I think it's very important for the future of healthcare that we learn our students how to become good team players and even leaders of the team, because other professions expect that from doctors. And then the last one is about system approach, and I'll tell a little bit more about system and system approach in the next things, because if we, especially on system approaches, talked about social accountability. How do we, when we are a doctor, we are working in a system, and part of the things we have to look into is the social accountability of what we are doing, or what we want to achieve by our practice. And so I continue with the second thing within the global movement, and that's there has been made a global consensus of social accountability. And when we talked about solutions all the days, I think one of the important things is to introduce social accountability into the practice as being a responsibility for practices and for doctors. This global consensus says, well, the background is there are increasing challenges. We are, as medical schools, very good at handing over scientific knowledge and training physicians to become good doctors as a doctor. But within the 21st century, I already told you, we have new challenges. How will we realize to improve quality, equity, relevance, and effectiveness in healthcare delivery? How will we try to be part in reducing the mismatch with with priorities of the community in which we live? I think this is a major, I think it's very nicely shown how important primary care can be even in a crisis, and it has to do with this. How are we going to react on new social and community priorities as a medical profession? And it's hopeful to see it happening, and primary care taking the lead in that. So redefining the roles of health professionals and thinking as becoming team leaders is also one, and trying to provide evidence of what we are doing on people's health status and the equity of our work. So the consensus says there are 10 strategic directions for medical schools to become social accountability. It's especially also on medical schools, but I think you also can say it on continuous professional development. And the global consensus is done between 100 institutes and individuals, experts from all over the world. It's published on the net. I'll show you the website in a minute. What they want to make sure is that medical schools respond to future health needs and challenges in society. And to reorient education, research and service priorities accordingly. And transformative learning, as I said, will be a very important aspect of doing so. Another very interesting thing, and I heard in the last speaker also how this is starting. You can say politicians, well, they are not good doing their work, but on the other hand, we will have to work together to find solutions. And we will have to tell politicians what are the problems and look together to find global and local solutions for that. So strengthening governance and partnerships with other stakeholders will be very important. The last one, and of course when we are speaking about quality, it always comes back, use evaluation and accreditation to assess our performance and impact. So this is the website where you can find it, then I want to end my presentation with a story about medical schools already trying to establish and to implement this advice of the global consensus. There exists a global network of institutes, and it's called the NET, which is Training for Health Equity Network. It's worldwide, and what they try to do is, from the fragmentation of having community priorities, a health system which is not accordingly to these priorities, and academic institutions which are teaching, but not always what the health needs system or the community needs, to become really partners and finding a symbiosis to attack the problems and the new challenges coming within the 21st century, of which we already heard a lot. The net schools, here you have an overview. There are about 10 now, and the 4 newcomers are coming into this network, and they are meeting regularly, I think twice or 3 times a year, to meet each other and to tell about their experience and strengthen their network. So they use the definition of social accountability as being the obligation to orient their education, research and service activities towards the priorities and the health concerns of local communities at the first step. The region or national level to which they have a mandate. These priorities are jointly defined, that's the point, by government, health service organization, the public, and the academic people want to subscribe these priorities and try to respond on that. And they have a conceptual model for doing this. Assessing the health needs first, of the system, of the community, and of individuals within it. Identify how they can find actions and resources to tackle them, design and implement strategy and some actions, evaluate, and afterwards, after having learning, starting again with the quality circle. It's nothing more than that. But it's a quality circle focused on the engagement to do so together with the community and other stakeholders on all activities within the academic world. So what are the underlying assumptions? The underlying assumptions is that you first have to analyze the problems and understand how the context is and what the social determinants of health are in your local community. Assess the needs of the reference population, the population of your practice or the population of your local, of national target group. Analyze current and project health system, workforce and services needed also. Is the workforce appropriate or not? And find the gaps in it. Then organize within the school activities on education, research and services to tackle those priorities, and especially the priority health needs, including that of the most disadvantaged. Okay. Find partnerships to do so. I'm repeating myself a little bit, and then start to measure improved outcomes and see if health outcomes are better, or start again with your quality cycle to try to do it again. So one of the medical schools within the net is the University of Ghent, and I'm not the architect of the curriculum. One of the architects is sitting right over me, but I'm a privileged observer of what is happening there, and I'm very happy to tell you a little bit about it. The mission statement of the faculty, within the mission statement already is stated that the faculty wishes to provide solutions to health-related needs, and particularly of the social weaker groups, both in Belgium and in the Third World. So this is very ambitious. I don't know how many mission statements of faculties have this in it. And it has been certainly one of the big inspirers of this is Jan de Mazene, who has been one of the 5-star doctors in, some years ago, and I think he's one of the architects and one of the driving forces to put this into the mission statement, and not only to put it in the mission statement, but also to translate it into a curriculum. And the curriculum is throughout the 7 years, which we are reducing to 6 years within some time, of the medical education, and continues within vocational education also. So from the first year on, they get a 4-week training, which is called Health and Society, in which students are get lectures, but also personal and individual work to focus on health and society and the links between health and society. Within the block are psychologists, anthropologists, sociologists coming and teaching and bringing an overview of how complex this relation is between health and society. In the 3rd year, they are doing a project for a week, which I will show you in a minute more in detail. And transversal within the curriculum, you have the independent learning line, in which they have to do a literature search in health and in inequities, for instance. Being part of that, and also we have the skill line, in which communication skills Also for intercultural communication and things like that is introduced and learned to the students. And then they have the possibility of attending, or they have the obligation of attending 10 of the 30 lectures in the Studium Generale, which give also a more broader overview of society and health, and not only focusing on medical knowledge. So I want to tell you a little bit more about the COPC week, which is in the 3rd year, because I think it's a very nice project, and it's very interesting to see how students are doing it. And it's based on the community-oriented primary care report, which you see here. So I think community-oriented care, social accountability are very close to each other and are enhancing each other. And again, you see this circle being a quality circle on how you do it and how you can involve the community or you can involve health and health workers within the community work. Jochen, you remember we went to the local practice within Ghent, which has really been inspiring for this, and they are one of the places in which students come to do this. So what are they doing? The students are divided in groups of 10, and within this group they are spread over the Ghent area, especially in the suburban regions where there is a lot of socio-economic lower social class. And there they have to define and characterize the community. They go into the community, talk to patients, and then they try to identify communities' health problems. And that's especially what they are doing, and they are urged to prioritize and to find and develop interventions. Not to do them, that's too much to do in a week, but in this week they have to do the left side of the circle. So in this way all students, all medical students have this community-oriented training to do so. And then maybe practices or university take over, or even the city. The city takes over some of the measures and try to implement them. Here you see the students going and making contact with patients and trying by talking to patients, to doctors, to field workers to identify possible problems and making up a list of possible priorities. And then they are coming together in the group, bringing together their findings and discussing them, and then they have at the end of the week a presentation to do for the professors, but not only the professors, also for field workers and for people from the local authorities who come to listen to them and to see what they have done and to reflect together with them on this thing. So this is one of the examples of things going on, but in the discussion we can go more in depth if you want, or Sarah can, after the presentation, tell you more about it. My conclusion is, as well for medical schools as for CME and continuous professional development, there are some essential things. One of the essential things is that you have to educate your students on principles of equity in health and in healthcare, and you have to help your students to reflect on it and to reflect on their own position within it. And I think this is very important. That's some of the things Tina said earlier. For CME, I think it's also very important to address this topic of equity in health and healthcare and social accountability of you being a doctor and having responsibility for the community in which you live. And being a leader, if you want it or not, you're a leader in your community. The topic of equity in health and healthcare should be integrated into all years and transversal throughout the medical curriculum for all students. I don't think it's only something for primary care, but it's also important for specialists to have this training. I think health professionals should be able to evaluate equity in their own practice. I think this is some very important steps to find a little solution and a step forward. And last, I think it's what we see is that it's difficult to convince medical students about the importance of the topic of inequity in health and healthcare. Because students especially are interested in the medical problems and how to treat diseases, and it's difficult to convince them. Once they stepped in, then they find it more interesting, but how to convince them to do so is not easy. And it's not only about inequity, it's about quality in general. It's difficult because they're not in practice and not and have not that aspect of how we organize your practice and do so. But we know doctors are leaders in their community and they should be convinced to take responsibility, and we have NCPD to make them aware of that. So, if you have any more questions or you want some contact afterwards, I'm very eager to work together and to talk more to you about it.
Thank you, Piet.